Hi, everyone, and welcome to another episode of Dr. Gilbert Hosts. For all of us at APDA, every month is Parkinson's Disease Awareness Month because we work tirelessly all year round to support and serve the Parkinson's community. But April is officially Parkinson's Disease Awareness Month, so it's a great opportunity for you to get to know the Parkinson's community and become more involved with everyone here on the live chat. We also want everyone to show your support for people impacted by Parkinson's. So we've got some great suggestions for you about how you can get involved during this month. So the first thing to be aware is how to raise awareness about Parkinson's. April's a great time to come together and raise awareness about Parkinson's as we continue to share hope and strength with everyone living with Parkinson's and their loved ones. So how do you raise awareness? We make it easy for you. Follow APDA on social media and like and share our posts. And in that way, you can help spread the word about the latest in Parkinson's news, about upcoming events, and more. You can also visit our website, where you'll find a wealth of reliable information on all things Parkinson's. You can take the time to learn more about Parkinson's yourself, or you can find a web page or a blog post that you think may help out a friend and send it along. Also this month, get connected. Make this month to reconnect to your local Parkinson's community. You can try a new fitness class, get back to a support group, start a support group for the first time, volunteer at an upcoming event, and see if there's an APDA Optimism Walk near you. Contact your local APDA chapter to see what's happening near you as well. So we have lots and lots of opportunities for you to find out what's going on and get involved. You can also join an online program by visiting our virtual calendar, apdaparkinson.org/events, and find out whether there's a virtual event that you can take place in or participate in, which does not need you to be in person near one of our chapters. In addition, this month, you may find that it's time for you to lend an ear or a hand to somebody you know with Parkinson's. Make plans to spend time with somebody who you may not have connected with in a while who has Parkinson's. They may need to talk. They may just want to chat, maybe have some coffee, maybe just reach out with a phone call, go on a walk, maybe help out with a project at home. And this also goes for care partners of people with Parkinson's that you may know. You may want to offer to lend a hand, maybe take something off their plate so they can get to have some free time for themselves, give them a call, see how they're doing. That's also super important. And if you yourself have Parkinson's or a care partner, April's a good time to recommit to yourself and focus on your needs, because when you do, you'll have more energy to educate and inspire others. Maybe you've been putting off a neurologist appointment. Maybe you've been putting off another type of doctor's appointment. Now is the time to make those appointments. Maybe you've skipped some physical therapy. Now is the time to get back on track. Probably have been putting everyone else's needs first, but try to take a bit of time for yourself. Do what makes you happy. Read a book, take a nap, call a friend, make time for you. Another great opportunity this month, raise funds for APDA or another Parkinson's organization. Whether you raise funds for one of our Optimism Walks, you want to create a do-it-yourself fundraiser like a bake sale, car wash, karaoke night. The more funds we raise, the more people we can help. So your efforts are greatly appreciated. Now, if you've never fundraised before, we can help. So just reach out to us. We can give you some easy tips to get started. You can also just make a donation of any size to APDA. Every donation, no matter how big or small, makes a difference. Now, no matter how you plan to get involved, we appreciate your support because together we can share hope and strength with everyone affected by Parkinson's. And now we're going to turn to what we do best on Dr. Gilbert Hosts, which is to answer your questions. For those who are familiar with Dr. Gilbert Hosts, you may recall that a few months ago, I did a broadcast with Dr. Drew Falconer. We entitled it Ask the Doctors Anything. And on that broadcast, we answered many of your very frequently asked questions. I invite you to watch that broadcast on our YouTube channel. The link will be posted in the live chat. I also write a weekly blog on our APDA website entitled A Closer Look, and I've answered many more of your questions in recent blog posts. One blog covered questions related to progression of Parkinson's and tremor and other motor symptoms. Another blog covered questions related to nutrition, physical therapy, and exercise, and I invite you to review those blogs and those frequently asked questions as well, and we will also place those links in the live chat as well. But there are always more questions. And so now I will try to answer some more of the most commonly asked questions that I get. And I also want to take your questions live that you may have for me now. So if you have a question, please go ahead and ask your question now in the live chat. Now, in order to participate in the live chat, you will have to log into YouTube or Facebook. And I want to make sure you know that we may display your question along with the name and photo that you're logged in with. And so, with that, I would like to start with some very, very common questions. The first one that we get all the time is, are there any new treatments on the horizon for Parkinson's disease? And this is a question that everyone's eager to know. We talk a lot about carbidopa, levodopa. Carbidopa, levodopa is sort of the mainstay of Parkinson's treatment. It is a medication that gets converted into dopamine in the brain. And dopamine is the chemical that's missing in the brain, which causes the lack of dopamine is what causes the motor symptoms of Parkinson's disease. And so replacing that dopamine in the brain is a very crucial part of treatment of Parkinson's and likely will always be. But people ask, this medication has been around for so long. What's new? What's new? And so I want to make you aware that one of the exciting new things on the horizon is that carbidopa levodopa is going to be available as a subcutaneous infusion. What does that mean? It's going to be infused, an infusion directly into the subcutaneous fat in the abdomen, very similar to an insulin pump. This has not been available to people with PD before. There are 2 companies working on this, and our understanding in the community is that this will become commercially available this spring and summer. And why that's so exciting is because carbidopa levodopa's big challenge is that although it works well to control the slowness and stiffness and usually the tremor of Parkinson's, what it can happen as the disease becomes more entrenched and more problematic, that can be very difficult to find just the right dose for just the right time. And there can be times during the day when the medication works well, times during the day when the medication doesn't work well, and you have these ups and downs during the day and these fluctuations. So the hope is that with a infusion that goes into the body continuously throughout the day, these ups and downs are going to be mitigated. And so the Parkinson's treatment community, the doctors who treat Parkinson's, are excited about this new potential medication, which is on the horizon. We have a question from Faye. I'm having trouble right now. I just took my medication. How do I get by this waiting time? So Faye is really alluding to the problem that I just mentioned, that this tendency for carbidopa levodopa to not be consistently give a consistently good response throughout the day in a nice even way. There can be ups and downs, and sometimes what's happening to Faye is that she takes her medication, but it doesn't work right away. There's this delay. And so that can be very, very frustrating because you're waiting for the medication to kick in. And that time where the medication's not kicking in yet can be 20 minutes, 30 minutes. It could be that the medication then kicks in and lasts maybe for 2 hours, then it stops working again. You have to take another dose. And then again, you have to wait for the dose to kick in, and you're kind of going up and down. Now, this phenomenon, which is called motor fluctuations or on and off time, very common, and it's something that Faye and many others deal with. This subcutaneous infusion that I mentioned earlier is a response that the pharmaceutical companies have come up with to try to address this on and off phenomenon. So that's very, very exciting. In the meantime, there are many other approaches that are available right now that can help with this on and off time. So, for example, your doctor may want to add a medication onto the carbidopa levodopa, which extends the life of the carbidopa levodopa. So a medication such as Comtan or entecapone can help with that. It can decrease the breakdown of carbidopa levodopa, making it last longer. A newer formulation is called opicapone. That can be helpful as well. There are other formulations of carbidopa levodopa that are longer acting, that are oral, a pill that is actually longer acting than the standard Cinemet. That can be an option to try to lengthen a dose and make the response time more even. So, Faye, I would definitely encourage you to approach your doctor and discuss different ways where you don't have to have that downtime, trying to tweak medications to make that response time more even. So, good luck to you with that, and hopefully you can get some relief from that really common problem. We have a great question from Robert. Any known progress with the Parkinson's vibrotactile gloves and clinical trials? So what Robert is referring to is that a few months back, there was some very exciting news articles about a glove that was developed in Stanford that seemed to really help Parkinson's symptoms and decrease tremor, and really seemed to be very transformative for the people that were videoed in these news articles. And everyone got very excited about these gloves, and they wanted to participate in any further clinical trials. I am not aware of any movement on this front. I know that the Stanford group is absolutely going to be doing more clinical trials with these gloves, and I'm very confident that they will continue to see these positive results. But I do not think that there's been any particular movement on this front. In order to monitor this yourself, instead of staying in the dark, you can go to the website clinicaltrials.gov, which is basically a compilation of all clinical trials that are open, available, closed even, yet to be open, but sort of registered already. And you can type in vibrotactile gloves, Parkinson's disease, and the trial will come up, and you can follow it yourself and see whether they are open for enrollees, etc. So definitely stay on top of that. I'll be staying on top of that as well. And together we'll see what progress is being made on this front. But very excited that will come to fruition soon. We are going to take a question from Kathy. Is focused ultrasound a treatment for Parkinson's disease? So thank you so much, Kathy, for this question. Focused ultrasound is a treatment for Parkinson's. So what is focused ultrasound? Focused ultrasound is a technology in which a person has an MRI, so a very detailed MRI of their brain, and correlated to that is a procedure in which a person wears a cap, which shoots ultrasound waves out of the cap, and where the ultrasound waves converge to a small little part of the brain, those ultrasound wave, the energy all converges on one tiny little piece of the brain and burns a hole in the brain, creating a lesion in the brain without any destructive surgery, without opening the brain with a scalpel or putting anything in the brain at all to make this lesion. The lesion is created from the convergence of the ultrasound waves. And this is very exciting. That is, of course, before this lesion is made, it's correlated to a very specific location that's found on the MRI. And in order to, and what this procedure is meant to do is to create a lesion in the abnormal Parkinson circuitry. So it disrupts the abnormal circuitry and resets the circuitry, thereby normalizing movement. And this is really a variation on lesional surgery. Before, the common surgery done for Parkinson's called deep brain stimulation, which I'll talk about in a second. Prior to that, there was lesional surgery. The brain was opened up and a little lesion was created in the same spot, and that helped to normalize Parkinson's movements. The lesional surgery, sometimes still happens in some parts of the world, but in America, for the most part, the surgery that has been predominating for Parkinson's is deep brain stimulation. And in that surgery, a wire is put deep in the brain, tunneled out of the brain and connected to a battery pack at the chest. And then electricity is sent into the brain. And again, this electricity normalizes abnormal Parkinson circuitry. And that surgery, deep brain stimulation, has been done thousands and thousands and thousands of times in people with Parkinson's. It's not at all experimental, been done for decades and decades. And now we have another new option called focused ultrasound, where a lesion is created without an invasive surgery. And so now people are given two options. Sometimes they have the option of deep brain stimulation and the option of focused ultrasound. There are pros and cons to each. That is too elaborate a conversation to go through now. This is a conversation you need to have with a person who is able to do hopefully both of these procedures and is able to give you guidance on which procedure, if either, makes sense for you. So definitely something to discuss with your neurologist. and possibly with a neurosurgeon, if your neurologist feels that you may be a candidate for one or both of these surgeries, how to decide between these two and which one is best for you. So great question from Kathy. Thank you so much. So question from Angie. What Angie is asking, do you have any suggestions for impulsive or compulsive behavior that comes from pramipexole or carbidopa levodopa? So to give a little background, pramipexole is a dopamine agonist. It is one of a class of medications in which dopamine itself is not given to a person, but a chemical that stimulates the dopamine receptor. It's called a dopamine agonist. And there are a few that are available in the United States. Pramipexole is one of them, also known by the brand name Mirapex. There's also Requip or ropinirole, and there's also Nupro or the ratigatine patch. Those are the three main dopamine agonists that are available in the United States. There is a side effect of these medications, which doesn't happen to everyone, but can happen in some people, of impulsive or compulsive behavior on these medications. And this can be mild. It can be you like cleaning up a little more, or you shop a little more on the internet, and this can be very, very severe. So there have been cases of people who have impulsive or compulsive behavior where they're gambling, and they can be gambling away large amounts of their money. Some people may have hypersexuality as a problem, where it can be a real problem with their partner, or they may engage in sexual behaviors which are dangerous, like visiting prostitutes, or things that are not something that they had done prior, and can be something that can be life altering if not stopped. So it can be very, very, very difficult. People can do anything, any activity to an extreme, and so the if one has to assess. So as a physician who is prescribing these medications, if you are prescribing a medication, a dopamine agonist, a question that you need to ask every time the person comes is, are there any suggestions of impulsive or compulsive behaviors? And it can be tricky because you don't know whether, well, if somebody liked to go to Atlantic City every now and then before, and now they go a little more often, is that a problem? You have to sort of gauge whether this is a pathologic response. But it is something that really does need to be taken seriously, and explain to the person that this could be a side effect of medication. So if there is compulsive or impulsive behaviors from dopamine agonists, my suggestion would be to wean off of them. This is a side effect much like any other side effect. And if the side effect is not compatible with a good quality of life, then you move on to another medication. The way to get off of these medications has to be done very, very carefully. You do never want to stop a dopamine agonist suddenly, because there is another problem with dopamine agonists called the dopamine agonist withdrawal syndrome. You can actually have a pretty, some people, not everyone, some people can get off it without a problem, but some people can have a pretty significant withdrawal feeling when they get off of it too suddenly. So those medications have to be reduced slowly. So if you're having impulsive or compulsive behaviors and you're on a dopamine agonist, please bring it up with your doctor if the doctor doesn't bring it up themselves, and make alternate plans for other medications. You can also get impulsive or compulsive behaviors from carbidopa levodopa itself. It's much less common, but definitely can happen. And if that's the case, again, you want to discuss with your doctor how significant the compulsive behavior is. Is this a tolerable amount or not? And then you would have to adjust medications accordingly. So thank you, Angie, for alerting us to that very, very difficult problem. Question from Clarissa. Why does carbidopa levodopa not have much effect on non-motor symptoms such as orthostatic hypotension and micro handwriting or speech? Excellent question, Clarissa. Okay, so what carbidopa levodopa is a precursor of dopamine. So it's taken orally, and it is able to pass the blood-brain. Levodopa is able to pass the blood-brain barrier and be converted into dopamine into the brain. Dopamine itself does not cross the blood-brain barrier. So if you're given dopamine, you have other effects around the body, but you won't have the brain effects. That's what levodopa is. So levodopa is only going to improve the things that dopamine is responsible for in the brain. And that is primarily the motor symptoms of Parkinson's: the slowness, the stiffness, the tremor, and the walking, let's say. So those things can be improved by dopamine. There are many, many other symptoms of Parkinson's disease that are not motor related. So Clarissa mentions one, which is orthostatic hypotension. But there is things like constipation, urinary problems, mood disorders, sleep disorders, cognitive disorders. There are many, many what we call non-motor symptoms of Parkinson's. So if we're so focused on dopamine, how can we at the same time be so focused on dopamine, but also focused on all these non-motor symptoms? So the fact of the matter is that the damage in Parkinson's disease goes beyond the dopamine system. So we know how to help or to bolster the dopamine system. We have lots of medications that can mimic dopamine, are dopamine, lots of different formulations of dopamine. So we kind of have an armamentarium of dopamine related medications that we can give people for the dopamine problems. All the other problems are due to lack of other chemicals in the brain. So to take a step backwards, the reason a person has this lack of dopamine is because in Parkinson's disease, certain neurons die, and the neurons that die that are neurons that produce dopamine. But there are other neurons that die that are neurons that are involved in the serotonin system, or neurons that are involved in the acetylcholine system, or neurons that are involved in the other neurotransmitters. So there's and so we have to treat those problems with medications that are not necessarily dopamine medications. And so the problems of Parkinson's do go beyond dopamine and are definitely going to go beyond treating them, are definitely going to go beyond dopamine medications. So if you have a non-motor symptom that's due to a lack of serotonin, let's say, then the medication is going to, and that would be, let's say a mood disorder, then the medication will have to be a serotonin-like medication to treat the mood disorder. Now, you mentioned specifically orthostatic hypotension. Now, this is a complicated one because orthostatic hypotension can be a non-motor symptom of Parkinson's. That means that you have dysregulation of the size of the blood vessels, and if the blood vessels don't constrict quickly enough when you change head position, then you can have a drop in your blood pressure, and you can feel really lightheaded, and you need to maybe sit down or even lie down, and you can even feel the need to, you may pass out because you don't get enough blood to your brain. And so orthostatic hypotension can be a non-motor symptom of Parkinson's, but it also turns out that it can be a side effect of carbidopa levodopa. So if you are finding that orthostatic hypotension is not treated by your carbidopa levodopa, that's true, but it can also be making it worse. So that is definitely something to talk with your doctor about if you realize that carbidopa levodopa is not helping your orthostatic hypotension. You want to make sure that it's not causing your orthostatic hypotension. So you want to talk to your doctor about finding that fine balance between those two things. So that can be tricky. In terms of what you mentioned here, the micro handwriting and the speech, it is true that carbidopa levodopa may not have a great effect on either of those. It may help handwriting in some people, but not necessarily in many. Some suggestions for the micro handwriting. One of the suggestions that I love to give is using graph paper and trying to fit a letter in each box. And that helps you maintain a nice big handwriting. And that you can use as like a handwriting therapy to try to get that handwriting to be kind of more aware of the handwriting being big. Speech can be a real problem in people with Parkinson's, and definitely encourage you to ask your neurologist for a referral for a speech therapist. Speech in Parkinson's can have many problems. One of the problems is low voice that isn't a strong voice, and working on that with a speech therapist can be very, very helpful. So I encourage you, Clarissa, to find other ways to treat symptoms of Parkinson's that are not carbidopa levodopa when the symptoms are not responsive to dopamine. So thank you so much for that. So we have a question from Aphrodite. Dr. Gilbert, what are your thoughts on the use of botulinum toxin in Parkinson's? So we'll address that question. So botulinum toxin is a toxin, which is a substance produced by a bacteria. And when it's harnessed, it's just a tiny little amount that's produced by the botulism bacteria, the bacteria that causes botulism. When it's harnessed in a little vial and injected into a particular muscle, what it does is that it weakens that particular muscle. When you have botulism in your whole body goes weak and it can be deadly even. But if the toxin is very, very carefully injected into specific muscles, then you can weaken specific muscles. That is what botulism does. Botulinum toxin does. So it's not going to be a treatment for Parkinson's. It's not going to improve movement. It's not going to improve slowness. It's not going to affect the brain. All it can do is weaken specific muscles. But what is the use of weakening specific muscles in Parkinson's? Well, there are some uses. And so one problem that can happen in some people with Parkinson's is something called dystonia. Dystonia is a twisting movement of certain body parts that can be sustained. Sometimes it happens in the neck. Sometimes it can happen in the foot. The foot can turn in, the toes can curl. This can sometimes be a side effect of Parkinson medications. This can sometimes be a dyskinesia equivalent. So dyskinesias are abnormal movements of certain parts of the body that are related to taking medications. Sometimes the movements are dance-like. Sometimes they're dystonic, where they're twisty. Sometimes the dystonia is because of a lack of medication. So dystonia can be a side effect of Parkinson medication, and it could be also a sign that you're not getting enough Parkinson medication, kind of two opposites on the spectrum, but you can get both those reasons for having dystonia. So if you do get dystonia as part of your Parkinson's, using botulinum toxin injections can be helpful to relax those specific muscles. Sometimes the dystonia in Parkinson's is painful and can be very annoying. And so using botulinum toxin can be helpful in that specific situation. Sometimes people with Parkinson's drool, and using botulinum toxin injections in the salivary glands in the cheeks and also in other salivary glands in the face can help reduce saliva and decrease drooling. And so that can also be a use of botulinum toxin in Parkinson's. Sometimes people with Parkinson's sweat too much, and sometimes injecting botulinum toxin in specific locations can decrease that sweating. So sometimes people get sweating along their hairline, and having botulinum toxin injections there can be helpful. The sweating issue botulinum toxin may or may not be a useful strategy, because sometimes the sweating is everywhere and there's no way to inject the whole body to decrease sweating. But if there are specific parts of the body that sweat annoyingly, that can be another approach to treatment. So there are specific uses of botulinum toxin in Parkinson's, but it's not a treatment of the underlying disease, and it's not a treatment of some of the fundamental problems of Parkinson's, which is slowness and stiffness of movement. We have so many questions coming in, and each one is really fantastic. So we'll try to answer just as many as we can. So our next question is from Tom. Does DBS help with non-motor symptoms? Great question. So for the most part, the answer is no. In a similar way that dopamine treatment does not help non-motor symptoms for the most part, DBS tends to follow dopamine. So what dopamine helps, that's what DBS helps typically. And so it is not typically a treatment that's touted for people who have a serious heavy non-motor symptom burden. So usually if a person goes for a DBS evaluation, the DBS surgeon will want to know what's your response to dopamine. And that's what you can expect as your DBS response, but your DBS response will be more sustained. You won't have that ups and downs that we talked about earlier. You will have a more sustained response, and that's what you're looking for the DBS. So let's answer Mary's question. Is there a point in the disease progression where levodopa is no longer enlisted as a treatment? Great question. So for the most part, as Parkinson's disease progresses, what tends to become the more prominent piece of the disease and become more burdensome are the non-motor symptoms. They can become much more problematic for the person with Parkinson's than the motor symptoms. So the non-motor symptoms that some of them that we talked about already a little bit: blood pressure control, cognitive issues, sleep disorders, anxiety. These things can become the driving force of the disability. And as we mentioned before, levodopa is not the treatment for those non-motor symptoms. So in that regard, levodopa becomes less of the focus as Parkinson's advances, because many other symptoms may become front and center, which are not treated as well by levodopa, or not treated by levodopa at all. In terms of motor symptoms, levodopa, as the disease progresses, also changes. And as we mentioned, the levodopa whereas in the beginning of the disease, levodopa may have given a nice, even response when taken orally. As the disease progresses, there can be these ups and downs where the medication does not kick in quickly enough. It doesn't last for very long. So you might have these ups and downs, and that can be the major problem with levodopa as the disease progresses. And so the response to that is changing the medication in some way so that you get a more even response. And that was what we talked about earlier as well. So levodopa should remain a good treatment for the motor problems of Parkinson's as the disease progresses. But with all these complications of the treatment, there needs to be an adjustment of the medications in some way as the disease progresses. So yes, to Mary's question, so levodopa is going to be enlisted as a treatment throughout the condition. There really doesn't come a point where the person is like, well, levodopa is doing nothing. Levodopa is going to be helping the motor symptoms even in advanced stages, but its impact on quality of life may decrease, or I think that is correct. The impact will decrease because other problems that levodopa cannot treat take over, and levodopa is just not as effective for the long term. We are hopeful, as I mentioned for the first question, with the subcutaneous levodopa, with a more even distribution of the medication, that will be a great benefit for people with disease as it's advancing. So let's hope for that. We have a great question from Mike, which is: does it benefit a patient with Parkinson's disease to delay starting levodopa, since our body can become more tolerant and after 4 to 5 years can lead to dyskinesias? Okay, so thank you so much, Mike, for this question. And it asks this question all the time in different variations. And so researchers have tried to study this question: does it benefit a person to delay Parkinson's? And there was a great paper a number of years back where it looked at 2 different cohorts of patients. One group of patients who were treated in Western Europe, who got medication, pretty relatively early on, and then another group that was looked at from a country in Africa where treatment is much less robust, and people on the whole got the medications much later in their disease, and has compared 2 groups of people and saw when did they develop dyskinesia. So it turns out that people who received the medication later in their disease course did not have 4 to 5 years without dyskinesias. They had much less time without dyskinesias. So they got the medication, let's say 4 to 5 years into their disease. They started taking the medication and they got dyskinesias pretty much right away, after 6 months to a year. The people who got the levodopa earlier had that 4 to 5 year honeymoon period before their dyskinesias started. So what does this mean? It means that the 4 to 5 years on levodopa is not what causes the dyskinesias. It's the disease state that causes the dyskinesias. It's the brain at a certain place in the disease, which then sees levodopa. That combination is what causes dyskinesias, and not the actual presence of levodopa in your brain for that period of time. So what this paper concluded is that really does not do anything to withhold levodopa for those 4 to 5 years to prevent dyskinesias. It will not prevent dyskinesias by withholding the medication. And you basically have 4 to 5 years of less good quality of life because you aren't moving as well. And the other flip side is, if you're not treating the person, or you're delaying the medication by that time in order to prevent something that will happen anyway, you're basically not allowing the person to maximally exercise. And that is really key, because you need to exercise in a relatively pretty rigorous way to reap the benefits of neuroprotection, which we have not yet discussed at all in our questions. But exercise can be a very powerful tool in Parkinson's disease. And so not treating a person maximally sort of early on and hindering their ability to really move well can shoot yourself in the foot. So you have to keep that in mind as well. So the general tendency of people who treat Parkinson's is, you don't necessarily as soon as you suspect Parkinson's, they don't swing their arm, or they have a little bit of decreased expression on their face. You do not have to treat immediately at all. What you want to do is make sure a person is on medication if they are not able to maximally exercise off medication. That's at least my practice. And so you want to assess a person. Certainly, you do not have to prescribe carbidopa, levodopa the second you diagnose Parkinson's, but you do want to keep a close eye to make sure that the person is really getting into their exercise. I hope that helps, Mike, to answer your questions. Now, in terms of the development of dyskinesias from carbidopa, levodopa, major problem. I do not want to minimize dyskinesias and their effect on people. But dyskinesias are a spectrum as well. There's some people who have some mild extra movements that they don't notice and their family doesn't notice, and the doctor may be the only one to really kind of pick up on some subtleties, all the way to the very severe dyskinesias, which are socially embarrassing and can cause falls and all the rest. So everything in Parkinson's and everything in medicine is a spectrum. So you want to see where the person is on that spectrum, and then make adjustments based on that. So if someone has dyskinesias that are significant, you would want to try to adjust their medications to reduce the dyskinesias, or prescribe a medication to decrease dyskinesias themselves. So definitely thinking about dyskinesias and trying to minimize them is very, very important as part of Parkinson's treatment. A question from Rod. Are Parkinson's tremors always specific to the hands? The answer is no. Parkinson's tremors can be the leg, the foot, can be the torso. Typically, the head is not a Parkinson's tremor place. Head tremor is more commonly a different tremor disorder called essential tremor, but other parts of the body can definitely be affected by tremor. Okay, let's see what other questions have been posed. So we have a question from Barb. Does the medication or Parkinson's cause anxiety, and how do you deal with it? Excellent question. So in my assessment of people with Parkinson's, it's the Parkinson's itself that causes anxiety. It is an extremely common non-motor symptom of Parkinson's. It can be extremely debilitating. It can be very much life-altering. It can really impact quality of life in a major way, and needs to be addressed. I mean, people will say that their quality of life is so impacted by this problem. They're constantly worrying. They wake up worrying. They can't really calm down throughout the day. They can't enjoy anything. That the anxiety is really very overpowering. So how do you deal with anxiety? And so the lifestyle modification way of addressing anxiety is cognitive behavioral therapy. There are great strategies that can be taught to help somebody overcome their Parkinson's anxiety with ways of thinking, ways of sort of compartmentalizing the anxiety, externalizing yourself from the anxiety, and visualizing the anxiety. There are strategies that can be taught and practiced to get the anxiety under control. And so that is definitely something that I would advocate if somebody has a lot of anxiety, to ask their doctor about a cognitive behavioral therapist to help teach these skills about how to get the anxiety under control. So that's definitely something to pursue. If that is not enough, there are medications that can help as well. We think of anxiety as sort of the sister or the other side of the coin of depression. And a lot of our medications for depression can be very helpful in anxiety as well. And so that is definitely something to talk with your doctor about as well. So definitely would not just accept anxiety is not something you just want to accept. You want to, try to pursue treatments so that you can, get a better quality of life for sure. We have a question from Robert. What about treating freezing and festination when medications are ineffective? So another fantastic question. So freezing of gait is a common abnormal gait pattern, which is seen pretty much exclusively in Parkinson's disease or related disorders. It can be disorders that are Parkinsonian, which are primarily freezing of gait and not some of the other parts of Parkinson's, but primarily it's this group of disorders that can have freezing of gait. And in this gait pattern, there are sort of stutter steps on the floor. A person takes multiple steps in place. Their torso may be trying to move forward, but the rest of their feet are taking these tiny little steps in place and not moving forward. And it can be very debilitating. People get very frustrated. They can't move forward and they can fall. And so it's a huge fall risk. Festination is another abnormal gait pattern in Parkinson's disease where you kind of take running steps and can't stop. People can take these little tiny running steps and maybe, get stopped by running into a wall and that kind of thing. So how are these disorders treated? So often people think that these are not medication responsive, which isn't necessarily true. Sometimes freezing of gait is definitely responsive to medication. The person will have freezing of gait when they're off, when the medications do not work, and then freezing of gait goes away when they're treated well. So definitely making medication adjustments you want to assess. But there are many times when freezing of gait does not seem to be medication responsive, and this can be very frustrating for everyone. So how do you deal with that? So first and foremost, there's physical therapy. And my guess is Robert has been through physical therapy, but really want to reiterate that for everyone. Physical therapy can be a real linchpin, really critical part of freezing and festination treatment. And what does physical therapy do? It tries to retrain your brain into how to get out of those abnormal gait patterns. So the brain works in very mysterious ways, and ways to get out of a freeze can be very sort of prescriptive from this person to person. There are certain things you can do to get out of a freeze. And what are some of those things? You can walk to a beat. So tapping out a beat and walking to that beat can help a person get out of a freeze. Stepping over a line. So if a person's sort of doing that stutter step thing in place, putting a line in front of them for them to step over, having a visual cue like that can be very helpful in keeping the momentum going and moving forward. There are sometimes a marching in place, picking up your feet really high, picking up your knees really high can be a way to move forward as well. So tactile cues, visual cues, auditory cues, these are all ways of kind of getting a person out of a freeze and making the walking normalized. So that's something you can be taught and something that physical therapy can be helpful with. There is a specific walker called a U-step walker. This can be very helpful to people with Parkinson's disease. It's a heavy walker, so some people don't like that because it's too heavy, but the walker sort of encircles you in a U, and it can be very stabilizing. So that can be a good thing. There are two other aspects to this walker that can be helpful for a freezer is that it has a reverse braking mechanism. So instead of going and you have to press something for it to stop, it is braked in its neutral position and you have to press a lever to go. So this is helpful if somebody gets stuck in a freeze. The walker stabilizes around you. It doesn't go because you've let go, and you have that sort of stable base, and you don't necessarily topple over when you freeze. Whereas another walker, which can just go, so your feet are doing the stutter step, but your arms are taking the walker in front of you because you haven't braked the walker. So that's a nice thing about a reverse braking mechanism walker. And the other thing about this walker is it has a laser light. If you press a button, a laser light appears on the floor. You can step over the laser light. That's the visual cue to get out of a freezing of gait. So those are other tips and tricks to try to help people who have freezing of gait as a major problem. If medications themselves are not going to be helpful, then we can offer some of these other lifestyle modifications to help. Okay, so we're at 3:45. We've answered many questions, but of course there are many more questions to answer. I'm going to answer a question from a care partner, which comes in very, very frequently, which is, how much should I be doing for my husband and how much should I let him do on his own? And this is a question that I get in so many different forms. And I thought it would be really good to answer this type of question here as well. And that's a question that is very, very difficult to answer, of course. But it's, hearing from different care partners about how to address this issue really comes down to a conversation with the person with PD about, what it is that you're trying to accomplish. You want, as a care partner, you want to encourage your person with Parkinson's to be as independent as possible, but you also want to help them at the same time. And so really having that open communication about what it is they're really having trouble with, what it is they can do on their own, and what it is they need help with. And really trying to sort that out between the two of you. So you are being supportive of their independence as well as being supportive of their needs, and trying to strike that balance. I think really the only way is to have a communication between the two people to really assess. So we are going to take a question from Doug, which is, can Parkinson's cause people to feel cold? Great question. So Doug, yeah, the answer is yes. It is a less talked about non-motor symptom, temperature control. And in fact, my blog tomorrow is going to be about this topic. So please go to our website and follow our link to our blog. And tomorrow, an article about thermoregulation in Parkinson's is going to be posted. So it is true that people with Parkinson's can have difficulty regulating their body temperature, and they may feel too cold and they may feel too hot. It is difficult to treat this symptom without just invoking lifestyle changes. If you're cold, layers. If you're hot, cool showers, that sort of thing. There are no medications that so far have been revealing of a great solution to this thermoregulation problem, but it's really good to at least acknowledge that this can be a non-motor symptom of Parkinson's. So thank you, Doug, for that question. Of course, you never want to assume anything, that any of the non-motor symptoms are for sure Parkinson's. So if you're kind of tendency to feel cold, you want to talk to your primary care doctor. You may want your thyroid checked as well, because that can be a common cause of not getting that nice temperature regulation. So please be aware of that. So we are going to answer one last question, and then we will have to wrap up for the hour. And that question, which is a question that I get all the time, is, what are the new and exciting things or Parkinson's related research on the horizon that I'm excited about? So first and foremost, I want to acknowledge the very exciting Parkinson's disease research news, which was all over the media last week, about a biomarker discovery that sort of hit the presses last week. So just wanted to acknowledge that. So what that test is what's called seed amplification assay. Basically is a test looking for the abnormal pathology in Parkinson's disease of abnormally formed proteins called alpha-synuclein. And this test sort of takes a little bit of abnormally formed alpha-synuclein and mixes it with a person's cerebral spinal fluid, which is withdrawn from a needle through a lumbar puncture. And if there is also this abnormally formed alpha-synuclein in the cerebral spinal fluid, that will detect as a positive on this test. And this test is actually available for everyone. It is not covered by insurance yet. It is a test that your doctor can order. And in this new research, a large group of patients were studied using this test and sort of showed that this test, which was available prior, it sort of proved that it gave more validity to this test because a large group of people were studied, and it confirmed that this test was a good test for determining whether a person did or did not have Parkinson's. And more excitingly, in my opinion, than just confirming something that was established before, is that it was positive in people with premotor symptoms. So people who did not have the full-blown motor problems of Parkinson's, but had an earlier non-motor symptom that sometimes is related to Parkinson's, like a smell loss or a specific sleep disorder called REM behavior sleep disorder. And these people who did not yet have symptoms of the motor problems of Parkinson's also got this test and had a very high positivity, which suggested that this test can be used to diagnose Parkinson's in much earlier people, even before motor symptoms develop. So that, to me, was the most exciting part of that paper and that research, and that is very, very exciting breakthrough. And I actually wrote about this exciting news, and it's on our website. So we'll hopefully drop a link to that as well in our chat, so you can further understand the news that has been all over the media this last week or so. I'm very excited to tell you that in 2 weeks' time, we're going to actually be interviewing two of our researchers, APDA-funded researchers, who work in very exciting fields. One is working on virtual reality treatments of freezing of gait. Back to Robert's question, other ways of dealing with freezing of gait besides medications, if medications don't work. So we'll be discussing sort of new and exciting ways to address freezing of gait. And we're also going to be talking with a researcher who is looking at remote assessment of movements and how to diagnose, or how to follow a person's Parkinson's disease course, and how to follow their movements virtually. And so using tools where you can get an assessment of Parkinson's disease without going to a clinic, and having your disease followed over time without having going to a clinic. So very exciting technological advances that are helping us monitor, diagnose, and treat Parkinson's disease. So very excited about that, and very excited to be talking with our researchers in 2 weeks, 2 weeks' time. On that note, I think we have to wrap up. Our time has come to an end. And I want to thank everybody who has been listening and participating. We've had so many very, very excellent questions that I know many people have. They're very, very, very common questions that are very, very important for people to understand. So thank you so much for participating in today's discussion. And if you know someone who missed today's program, if you joined late, if you'd like to watch again, this recording will be available later today on our YouTube channel. And don't forget to subscribe to APDA's YouTube channel to watch new videos and live broadcasts. So for additional information and resources, please visit our website at apdaparkinson.org. So I mentioned already our upcoming broadcast that you don't want to miss. That will be on Monday, May 1st at 3 p.m. Eastern Standard Time. We're going to be talking to two APDA-funded researchers about their work. So please register for that. You do not want to miss it. Now, be sure to stick around for some final messages. Before I go, I want to thank you once again for joining us and for asking your great questions. We hope to see you soon on another APDA program. Have a great rest of the afternoon.
Hi, I'm Leslie Chambers, the President and CEO of the American Parkinson Disease Association. Each month across the country, APDA is providing support groups, exercise classes, and educational programs like this one to support the Parkinson's disease community. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. If you enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Your gift can help APDA support people living with PD through local programs, reliable resources, and groundbreaking research designed to find treatments and ultimately the cure for Parkinson's disease. Please donate today at apdaparkinson.org/donate. And thank you so much for your support.